tract. And as you all know that we have too many imaging modalities for assessment of the pediatric gastrointestinal tract, including the plain X-ray, the contrast studies, the ultrasound, the CT scan, the MRI, and some of the interventional techniques. And as you can see from this slide, that the most important imaging modalities for this particular domain are mainly the plain X-ray, the contrast studies, and the ultrasound. The value of the plain X-ray in assessment of the gastrointestinal tract will include assessment of the gas shadow, detection of some organ enlargement, detection of intra-abdominal calcification, evaluation of the lung basis for any pathology, as well as assessment of the bony skeleton seen in the plain radiograph. The value of the contrast studies will be directed for assessment of the position of the bowel for cases of malrotation, diagnosis of intestinal obstruction, diagnosis of atresia and stenotic segments, diagnosis of fistulae and blind pouches, diagnosis of vascular rings, and some of the therapeutic role. And actually, you know that barium is provided in a powder or ready-made preparations. It is an excellent contrast medium for opacification of the gastrointestinal tract, and it is completely inert without any reactive changes with the mucosa or the intestine. Also, we have what's known as water-soluble contrast medium, which is known as the gastrographene. And this gastrographene can be given for the neonates and also in cases with suspected bowel perforation and some cases with intestinal obstruction as well. But please note that this gastrographene has a high osmolarity and it should be given with great care, especially in dehydrated patients. We started the evaluation of the gastrointestinal tract by the esophagus, and we evaluate the esophagus by what is known as the barium swallow. And barium is introduced by mouth or through the nasogastric tube, and we follow the barium bolus under screen, outlining the esophagus in the frontal view as well as in the lateral view. We assess the esophageal caliber and outline. We also assess the gastroesophageal region for any abnormality. And this is the normal lateral view of the barium-filled esophagus, showing some indentations due to vessels and heart along the anterior aspect of the esophagus. Then some of the esophageal lesions, which can be assessed by plain film as well as by barium studies, will include the esophageal duplication, esophageal atresia with or without tracheoesophageal fistula, congenital esophageal stenosis, vascular rings, and hiatus hernia. And this is an example of double esophagus or esophageal duplication, and you know that the esophagus is the second most common location for duplication after the ileum, and the complete esophageal duplication as seen in this case is considered extremely rare, and you can see a nice demonstration of this particular issue. Then one of the common findings or common lesions in the pediatric age group and neonates is the presence of esophageal atresia and with or without tracheoesophageal fistula. And the presence of esophageal atresia can be diagnosed simply by introducing the nasogastric tube. Then you can see that the tube is not going directly to the stomach, instead it curves inside the esophagus itself. Then this is the most common type of esophageal atresia with tracheoesophageal fistula, where you get a blind pouch and the lower part of the esophagus is directly connected to the trachea, and this is indicated by the presence of air in the gastrointestinal tract. And these are the remaining types of gastroesophageal fistula, of tracheoesophageal fistula. This is the most common type, and this is relatively less common, and this is more or less common, and this is the rarest type with blind pouch and direct communication to the trachea. Then in this example, you can see that the nasogastric tube is stopping here in the upper part of the esophagus. Looking inside the abdomen, you can see air in the stomach. Then you know that this is trachea, the esophageal atresia, with tracheoesophageal fistula, which is the source of this air in the gastrointestinal tract. But if you see that the nasogastric tube is stopping upward in the esophagus, where a blind pouch is present, and you look in the abdomen, you don't see any pattern of air, then you know that there is no communication between the esophagus and the trachea, and this is without tracheoesophageal fistula. Then if you introduce barium, you may be able to see the direct communication between the esophagus and the trachea, as in this particular case. This is the blind pouch, and here you can see the communication is nicely demonstrated. This is barium in the blind pouch of the esophagus, and here you can identify the communication with the trachea. In this patient with recurrent pneumonitis or pneumonic patches in the lung, the suspected tracheoesophageal fistula was tried to be evaluated by barium. Then a nasogastric tube was introduced and the barium was injected, and no communication between the esophagus and the trachea. But whenever you draw up this nasogastric tube and they inject the barium high up in the region of the neck, then you are able to demonstrate the very well-known type of tracheoesophageal fistula, which is known as the H-shaped type. This is the esophagus, and this is the trachea where barium is seen inside. Then congenital esophageal stenosis is the mild form of esophageal narrowing and is considered the mild variant of esophageal atresia, and is usually a short segment and is located in the distal part of the esophagus, as you can see in this case. Also, vascular rings are simply diagnosed by barium swallow whenever you can see in the frontal view indentations on the barium-filled esophagus. And this corresponds to the indentation of the, this is a case of double arch aorta, and this is the major arch indenting the esophagus from the right side, and the minor arch indenting the esophagus from the left side. Then the diagnosis of hiatus hernia is very simple. Whenever you see that the gastroesophageal junction as well as part of the stomach are seen herniating in the lower part of the thoracic cavity, as you can see in this case and also in this case. Here is the barium-filled esophagus, and part of the gastric fundus is seen well above the diaphragm in the chest, diagnostic of hiatus hernia. Then some of the acquired abnormalities will include the gastroesophageal reflux, the achalasia, foreign body ingestion, caustic ingestion, and esophageal stricture, as well as esophageal varices. And this is an example of gastroesophageal reflux. And whenever assessing this, you should not introduce any nasogastric tube inside the esophagus. You just let the patient to swallow his saliva, then the gastroesophageal junction will open and barium will come back from the stomach into the lower part of the esophagus, as you can see in this case. And this is another example. Here you can see an apparently competent gastroesophageal junction, but whenever the patient swallows water or saliva, then the gastroesophageal junction will open and barium will come back from the stomach into the lower part of the esophagus. And this is also a classic appearance of gastroesophageal reflux, where you can see the barium is refluxing back into the lower part of the esophagus. And one of the common causes of gastroesophageal reflux is the hiatus hernia. And here's the hiatus hernia with a considerable refluxing of barium into the lower part of the esophagus. Then achalasia of the cardia is rare in children, and this achalasia will present in only 5% of cases in childhood. And the symptoms of achalasia in the pediatric age group will be similar to the gastroesophageal reflux, where in older children it will simulate the adult complaint. And these are the major symptoms, including dysphagia, chest pain, cough, vomiting, and poor weight gain. Here you can see the esophagus, which is dilated, tapering into a very narrow segment, which is the aganglionic segment in the distal part of the esophagus. And this patient with achalasia of the cardia, smooth distal narrowing of the esophagus with considerable proximal dilatation. And you all know that these patients usually develop recurrent form of aspiration pneumonia, as you can see in this chest X-ray. Then the detection of swallowed foreign bodies is easy if the foreign body is opaque, but if the foreign body is non-opaque, you will not see in the plain film, and you may need some barium studies to detect the foreign body itself. Corrosive stricture is a well-known form of lesions in the esophagus in the pediatric age group, And this structure is characteristically very smooth, looking to the appearing as a benign lesion, but it's usually very long, affecting a long segment of the esophagus, as you can see here. And this is another case of corrosive structure of the esophagus affecting a long segment of the esophageal lumen. Then acquired esophageal strictures are usually the sequelae of surgical interventions, but other causes include caustic ingestion esophagitis due to reflux, and the symptoms of acquired esophageal strictures will include dysphagia, chest pain, cough, and vomiting. And here is an esophageal stricture which is secondary to reflux esophagitis. And you can see here this refluxing barium and the narrowed segment in the distal part of the esophagus due to reflux esophagitis. And you all know we can manage these strictures in the esophagus and in some parts of the bowel by the interventional radiology, introducing in the balloons, which can dilate these segments, resulting in a more or less patent lumen. And this is a simple example of esophageal varices, which appear as worm-like filling defects along the course of the esophagus in patients with portal hypertension. Then we came to the stomach, and the stomach is examined by the barium meal, and we introduce fluid barium and radiograph the stomach in different positions to see the fundus, the body, and the pyloric antrum. And also the examination is not finished unless you see the duodenal bulb as well as the duodenal loop. The congenital gastric abnormalities will include diverticuli, microgastria, gastric volvulus, and the atresia affecting the pyloric region or the pyloric area. Then this is a simple example of a gastric diverticulum, which is clearly different from gastric ulcer, considering that normal mucosa is going inside the diverticulum itself. And this is a case of microgastria, where you can see a very small lumen of the stomach with barium directly passing into the proximal part of the duodenum. And pyloric atresia can be diagnosed from the plain film by detecting what is known as the single bubble. The single bubble means that the stomach is distended by air, and no air outside the stomach can be seen in the duodenum or the bowel. This is another case of pyloric atresia, where you see a single bubble, air bubble filling the stomach, and no air in the rest of the abdomen. The gastric volvulus is usually seen in cases of hiatal hernia, and we have two types of gastric volvulus. The first one is known as the organoaxial, and the second one is known as the mesentericoaxial. And in organoaxial, the greater curve will be above the rest of the stomach, while in mesentericoaxial, the greater curve will be to the right side of the abdomen. Then you see this is an example of organoaxial gastric volvulus, with the greater curve is seen above and the pyloric canal is directed below. And this is an example of mesentericoaxial gastric volvulus in hiatus hernia, and you can see the greater curvature of the stomach is to the right side of the abdomen. Then some of the acquired gastric changes will include hypertrophic pyloric stenosis, gastric and caustic and chemical gastritis, eosinophilic gastritis, Crohn's disease, gastric foreign bodies, gastric polyps, and lymphoma. And this is the classic appearance diagnosed by ultrasound of hypertrophic pyloric stenosis. You can see the pyloric canal with marked thickening and the elongation of the pyloric canal as seen by this ultrasound. Then this is another example where this is the pyloric canal, and this is the gastric pylorus, and you see this is the canal, which is where the muscles are hypertrophied and the canal is markedly elongated. Then this is an easy diagnosis by barium if you identify that the pyloric canal is markedly narrowed and the stomach proximal to the pyloric canal is distended due to delayed gastric emptying rate. And this is another example of hypertrophic pyloric stenosis, showing elongation of the pyloric canal and the proximal dilatation of the stomach. And you can see the gross specimen identifying or showing the marked hypertrophy of the muscularis, of the muscles of the pyloric canal. Then the history of ingestion of corrosive agents will affect the stomach and the esophagus as well as the stomach, especially in the pyloric region. and the positive history of caustic intake will be diagnostic. Also, you may have to diagnose some gastric polyps, and you see these are 3 polyps in the stomach in a patient with Gardner syndrome, and this syndrome entails the presence of gastrointestinal polyposis as well as multiple osteomas in the skeleton. And this is a juvenile polyp in the pyloric antrum of the stomach, outlined clearly by barium. Then eosinophilic gastritis or gastroenteritis is diagnosed by the presence of eosinophilia and the presence of hypertrophied mucosal folds as seen in the stomach as well as in the rest of the intestinal loops. Then this appearance is not specific for Crohn's disease. It can be seen in any gastritis or duodenitis, but the mucosal biopsy will solve the problem and reach the accurate diagnosis. Then foreign bodies in the stomach are diagnosed by filling defects that are mobile inside the stomach. And this is an example of a foreign body in the stomach. Can you predict the nature of this foreign body? Okay, this is the foreign body. All right. Then this is the one of the values of the CT examination of the pediatric gastrointestinal tract. Whenever you see filling defects in the stomach, and by CT you can see marked mural thickening and masses affecting the wall of the stomach in a case of gastric lymphoma. Then we came to the barium meal follow through, and by this we examined the small bowel. We give the patient barium fluid, and we follow the passage of barium through the intestinal loops until we reach the ileocecal region. And this is the normal appearance of the intestine, and this is the normal appearance of the terminal ileum as well as the cecum, which is important in this particular examination. Some of the congenital small bowel lesions will include malrotation of the bowel, which is an easy diagnosis, atresia of the small bowel segments, volvulus of the small bowel, meconium ileus, as well as meconium peritonitis. Normally, whenever you give the patient barium, then you will see the duodenum, and the junction between the duodenum and the jejunum, which is the site of ligament of Treitz, should be to the left of the spine and to the level of the duodenal bulb. Then if you see this finding, you consider it normal bowel with no rotation. But if you see that most of the duodenal and the jejunal loops are to the right of the spine and no loop to the left of the spine, then you consider malrotation of the bowel. And this is an example of malrotation of the bowel, where you can see the jejunal loops are to the right side of the spine and no intestine or few loops are to the left of the spine. Then duodenal atresia is diagnosed by what's known as the double bubble sign, where you got an air bubble in the stomach and another air bubble in the proximal duodenum. And you can see a bubble here and a bubble here. You can diagnose this from the plain film, and you may use barium. And this is barium. You see the stomach, which is distended, and you see the proximal part of the duodenum, which is distended, and no more barium, no more air in the abdomen. After treating this patient, and you can see air is in the small bowel as well. And this is another appearance of plain film showing the double bubble configuration, diagnostic of duodenal atresia. The stomach is distended by air, and the proximal duodenum is also distended by air. In cases of duodenal stenosis, you consider some barium will pass the stenotic segment to opacify the distal loop of the duodenum, and you can see dilatation of the proximal part as well as distension of the stomach, exactly similar to this configuration. Then the jejunal atresia, you will see the 4 bubble or the triple bubble appearance, where you can get an air bubble in the stomach, air bubble in the duodenum, and air bubble in the proximal jejunal loop. Then this is a surgical specimen showing the part of the jejunal atresia here, and this is the collapsed loop distal to the atretic segment. And this is another example where the supine film did not give conclusive results. Then aspiration of the fluids and the injection of air through a nasogastric tube delineated the stomach and the duodenal loop as well as part of the jejunal loop, and the air stopped here, indicating this segment, which is the site of atresia. Then ileal atresia cannot be diagnosed unless you inject barium per rectum. And here you will see that the colon is collapsed and very small because it is unused colon. And if you look through the abdomen, you can get dilated intestinal loops representing the obstructed small bowel secondary to this distal ileal atresia. Then the malrotation may be associated with the small bowel volvulus, which is considered one of the surgical emergencies. And here you can see that the duodenum and the jejunum are to the right side of the stomach, and the diagnosis of volvulus can be reached by the appearance of this corkscrew appearance of the proximal jejunal loops, as you can see in this particular example. And this is a classic appearance of malrotation with volvulus, where you can see the classic corkscrew appearance of the proximal intestinal loops. Then meconium ileus have a good correlation in patients with cystic fibrosis, and the meconium as an speciated material will obstruct the terminal ileum, resulting in small bowel obstruction. Then if you inject barium per rectum, you can see that the colon is collapsed, being unused, with the terminal ileal loops containing multiple filling defects representing the meconium inspissated inside of the terminal ileum. And if you look to this plain abdomen, you can see distension of the small bowel loops with gases, and the supine decubitus film shows also distension of the bowel loops. But injecting barium, you can see the filling defects of meconium inside the terminal ileum and the collapsed unused the colon distal to this side. Then this is a surgical specimen showing the tenacious appearance of the meconium itself, and this meconium may indicate surgical intervention to evacuate this particular material. And if you look to the abdomen of a neonate and you can see intra-abdominal calcification, then you can diagnose easily the possibility of meconium peritonitis, which is one of the complications of meconium ileus. And this is another case of meconium peritonitis, which occurs whenever the bowel is obstructed by meconium. Then bowel perforation will occur, and some of the meconium will be in the peritoneal cavity, resulting in these particular calcifications. Then the acquired diseases of the intestine will include perforation, necrotizing enterocolitis, small bowel intussusception and obstruction, as well as the protein-losing enteropathies and inflammatory bowel disease like Crohn's and TB, and meconium ileus we have discussed. Then if you would like to diagnose free air in the peritoneal cavity, there are some signs. Number one is the delineation of the falciform ligament by air. This is one of the signs. Number two is what is known as the continuous diaphragm sign. And air inside the abdomen will enable you to see the whole diaphragm, especially the segment which is below the cardiac shadow. Then if you are in doubt, you can have this cross-table view in order to see abdomen air underneath the abdominal wall. Then necrotizing enterocolitis is one of the surgical emergencies in some patients if not treated medically, mostly affecting the premature infants, and this is the incidence which is about 1.3 infants per 1,000, and it equally affects males and the females together. This disease can be easily diagnosed by plain films delineating air pockets along the wall of the intestinal loops, and also can be diagnosed by ultrasound. As you can see, the echogenic appearance of air in the lumen of the small bowel. The etiology of this particular disease is unclear and is suspected to be due to invasion of the intestinal mucosa by the intestinal flora, secondary to ischemia or decreased mucin production or the diminished immune response in the premature infant. And this is also another appearance of the necrotizing enterocolitis. And in many patients, you can also identify air in the portal venous system, which is an association of this disease. Then barium is actually contraindicated whenever you are suspecting necrotizing enterocolitis because of the fear of perforation. And the plain film is usually sufficient for reaching this diagnosis. Then this plain film is non-specific for a certain disease. You only see some bowel loops which are distended by air. Then if you have this ultrasound examination giving the classic appearance of donut sign or the target sign, which is diagnostic of a small bowel intersusception. Then intersusception in a longitudinal scan can be seen like this, which is known as the sandwich sign, where you can see the loop, one of the loops is invaginating inside the other loop by the ultrasound examination. Here you can look to these plain X-rays. You see non-specific findings apart from absence of gases on the right side of the abdomen. Then using the ultrasound, and you can easily diagnose this classic appearance of intersusception, giving the target sign with Worley configuration. Intestinal obstruction in the pediatric age group has many causes, but most of these causes cannot be reached from the plain film. But whenever you see gaseous distension of the bowel and in the erect position you can see multiple air fluid levels, then you know you are dealing with intestinal obstruction, and you look for in the clinical history for the possible cause. This is a case of intestinal obstruction, complicated surgery for perforated appendix, and you know that one of the most common causes of intestinal obstruction is surgical adhesions. And in the supine film, you see distension of the bowel loops by gases, and in the cross-table view, you can see the air fluid levels. This view, of course, is used instead of the erect position whenever you cannot radiograph the patient in the erect position. And here you can see this is the supine film, and this is the erect film with multiple air fluid level diagnostic of intestinal obstruction. And this CT image showed the classic appearance of intersusception, which is the cause of this intestinal obstruction. And the affection of the terminal ileum is very common by inflammatory diseases, especially the Crohn's and TB. And this is the normal appearance of the terminal ileum, showing normal caliber and normal mucosal pattern, where here you can see the stenotic terminal ileum as well as the ascending colon in a case of ileocecal tuberculosis. Then finally, we came to the assessment of the colon, and the colon is assessed by the barium enema. And this is the normal appearance of the barium enema, showing the different colonic segments as well as part of the terminal ileum due to reflux of barium in the small bowel secondary to incompetent ileocecal valve. And in this evacuation film, you can see clearly the appendix, which is well delineated by barium. Then one of the lesions in the intestine generally is the malrotation of the bowel, and here you can see the cecum, instead of being in the right iliac fossa, is high up below the liver, a diagnostic of one of forms of the intestinal malrotation. Then the colonic lesions can be assessed, including the agenesis or atresia and the stenosis as well, anorectal anomalies, small left colon or meconium plug syndrome, as well as Hirschsprung disease. And this is a simple plain X-ray in the lateral view, what we call the invertogram, and you put a coin at the suspected site of the anal opening, and you measure the distance between air in the distal part of the colon to the site of the marker. And you see here, this is a low level anal atresia or imperforate anus. And you can see here that the distance between the coin and the air is very long, and this is a high anomaly or high imperforate anus. And in both conditions, the low and the high, you will get some anomalies in the form of abnormal communications between the blind lobe and the urethra or the vagina. As you can see here, this is the bladder and this is the urethra, and you can see this communication with the urethra. The colonic atresia is diagnosed by barium enema. Whenever you inject barium, you can see that the patent part of the colon is small, relatively small, and barium cannot pass this segment, which is the site of atresia. And actually, because of this obstruction, you will get dilatation of the small bowel and distension with air. Then the small left colon or meconium plug syndrome means that there are some meconium inspeciated in the proximal part of the colon. This will result that the distal part of the colon will be relatively unused, and it will appear relatively small in size. Then you call it the small left colon syndrome. One of the common lesions in the colon is the Hirschsprung disease, and by this we mean there is a short segment of aganglionosis, usually seen in the rectosigmoid region, with huge proximal dilatation of the colon. Then this is another example. You see the fecal matter distending the distal part of the colon, and after injecting barium, you see the huge dilatation of the sigmoid and the area of narrowing here. And in this patient, you can diagnose easily intestinal obstruction because of the distension of the bowel with air, as well as the multiple air fluid levels. But injecting barium will delineate this particular area of narrowing with proximal huge dilatation of the colon, diagnostic of Hirschsprung disease. Then acquired lesion in the colon will include appendicitis, intussusception, necrotizing enterocolitis, as well colonic polyps and inflammatory lesions. Appendicitis is usually diagnosed by the detection of a small calcific shadow in the region of the appendix, either by plain film, this is known as appendicolis, or by ultrasound, which you can easily see this appendicolis in the region of the appendix, including the dilated appendix filled with fluid, diagnostic of acute appendicitis. And colonic intussusception is also one of the well-known diseases, and it will also be diagnosed by barium, as well as by the ultrasound showing the classic presentation. And you know that barium can be used as a therapeutic maneuver to reduce this intussusception, and this is a trial for reduction of this intussusception. And polyps can also occur in the colon, like this juvenile polyp, as seen as filling defect in the descending colon. And this is just a presentation of a case of ulcerative colitis in the colon in the pediatric age group, and you can see the typical ulcerations protruding or extending along the wall of the descending colon. Then to conclude, we have three major modalities for assessment of the gastrointestinal tract in the pediatric age group. And the first one, which is very important, is the plain X-ray, which is usually considered enough in the diagnosis of esophageal atresia with or without fistula, of pyloric and duodenal as well as jejunal atresia, in diagnosis of high and low level renal atresia, in diagnosis of intestinal obstruction, and in diagnosis of necrotizing enterocolitis, as well as free intra-abdominal air, as well as the diagnosis of meconium peritonitis by the detection of calcium in the peritoneal cavity. Then barium or water-soluble contrast media are helpful in the diagnosis of esophageal strictures, whether congenital or due to achalasia or due to corrosive, the diagnosis of tracheoesophageal fistula, the diagnosis of esophageal varices, vascular rings, gastroesophageal reflux, hiatus hernia, and gastric volvulus, as well as the hypertrophic pyloric stenosis, gastric ulcerations, diverticuli, foreign bodies, and polyps. Also, barium can help in the diagnosis of intestinal malrotation with or without volvulus, the diagnosis of meconium ileus inflammatory bowel disease, a small left colon syndrome, Hirschsprung disease, intussusception, and colonic polyps. And also, you do not forget the therapeutic effect of barium in dissolving meconium in some cases of meconium ileus, and in reduction of intussusception. And finally, ultrasound can be used for the diagnosis of congenital hypertrophic pyloric stenosis. Also can be used in diagnosis of necrotizing enterocolitis, acute appendicitis, as well as intussusception. And I thank you very much.